Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. You know, sometimes in medicine, you come across these conditions or procedures that sound, well, maybe a bit daunting.
Definitely.
But when you look closer, you often find these incredibly brilliant, elegant solutions. That's what we're doing today.
Right.
We're diving into a very specialized surgical procedure. It's called the Henley technique. It really highlights the amazing skill and precision of doctors and surgeons.
It really does.
So, okay, let's unpack this. What's our mission today? We want to really get under the hood of the Henley technique. It's designed for something very specific, very challenging: perianal horseshoe abscesses and fistulas. Sounds like a mouthful, right?
It does, yeah.
Don't worry, we'll break down what that means. We'll look at why this technique is so important and how it's just a fantastic example of blending deep anatomical knowledge with surgical finesse.
And that's such a key point.
Yeah.
Understanding why surgeons choose a specific path, especially for something that really impacts quality of life, it just shows the incredible skill involved.
Yeah.
It's not just about cutting and sewing. It's deep thinking, years of training, all focused on solving these really tough, hidden problems to make people's lives better.
I can definitely see that. So maybe the first step is just understanding the problem itself.
Yeah.
What exactly are these horseshoe perianal abscesses with associated fistulas?
Right, you have to start there. So imagine a really painful infection, but instead of just being like one spot, it spreads out.
Okay.
It forms this distinctive U shape, sort of wrapping around the lower part of the rectum. That's the horseshoe part.
Okay, a U-shape. Got it.
Now, getting a bit more technical, which surgeons absolutely need to do these usually start from a tiny infection source deep inside,
Right.
specifically in what's called the posterior midline intersphincteric space.
Right.
Think of that as ground zero.
Yeah.
From there, it spreads bilaterally to both sides through this really crucial area called the deep postanal space.
Okay.
Surgeons sometimes call that the keystone of infection, because if you don't deal with that space, the infection just keeps coming back.
Ah, the keystone. Makes sense.
From that keystone, it then moves outwards into the ischiorectal fossae. Those are basically fatty areas on either side of the rectum. That creates the final horseshoe shape.
Wow.
And then, the tricky part, the transsphincteric fistula tract. That means there's an actual tunnel, an infected pathway, that goes right through both the internal and external sphincter muscles.
The muscles for control.
Exactly. The ones vital for bowel control.
So it's not just a U-shaped infection. It's got this hidden tunnel system going through really important muscles. That sounds incredibly difficult to treat without causing other major problems.
Precisely. And that leads to the critical challenge for the surgeon. If you don't fully drain that deep postanal space, that keystone area, then recurrence, the infection coming back, is pretty much guaranteed. So you need a really targeted, really precise approach. It's essential. The surgeon has to nail that part.
Which I guess brings us right to the Henley technique. If understanding that keystone is so vital, what was the breakthrough? How did surgeons figure out how to tackle this effectively?
Exactly. So we've got this complex, hidden infection. For a long time, surgeons faced this awful choice. Go aggressively after the infection, but risk incontinence, or be cautious and risk it coming back.
A terrible dilemma.
Yeah. Then comes the Henley technique, developed way back in 1958 by J.R. Henley. It's a specific single-stage procedure just for these complex horseshoe cases.
Single stage. Okay.
Right. Sometimes it's called a posterior midline fistulectomy or midline sphincterotomy. The names themselves hint at the precision involved, like you said.
And the main goal, the promise, was to get rid of the infection and minimize the risk of incontinence, all in one operation.
That was the genius of it.
Yep.
A major step forward. Before Henley, that choice between cure and function was often brutal for both the surgeon and the patient.
I can imagine.
Henley found this narrow path to achieve both. And the fact that it's still a go-to technique today, decades later, that really speaks volumes about how well designed it with real surgical insight.
It really does. So when we talk about this kind of precision, what does it actually look like in the operating room? Can you walk us through the steps? How do these skilled doctors actually perform it?
Sure. It's a really methodical process, designed to be thorough but also careful with healthy tissue. It starts before any cutting, with really careful prep.
Okay.
First, an MRI fistulogram is key. It's a special MRI that maps out all those tracks, gives the surgeon a 3D view, helps confirm the horseshoe shape, and checks if the infection hasn't spread too high up.
Like a roadmap.
Exactly. Then, an examination under anesthesia EUA. The patient's relaxed, so the surgeon can do a thorough physical check to confirm the anatomy.
Makes sense.
And finally, positioning. The patient is placed in what's called the prone jackknife position. It gives the surgeon the best possible view and access to the area. Critical for precision work.
So mapping everything out, confirming it, getting the best view. It's like detective work before the main event.
You got it.
Yeah.
Preparation is everything. Once that's done, then comes the incision and drainage. The main cut is a posterior midline incision. A vertical cut right in the middle at the back from the dentate line, an important landmark inside down towards the tailbone, the cossagus.
Right over that keystone area.
Directly over the deep postanal space, yes.
Yeah.
That's how they drain that central abscess cavity, the keystone. Then, to handle the U-shape, they do bilateral counter drainage.
Meaning?
Additional small incisions out in those side pockets, the ischiorectal foci, to make sure all the lateral extensions are fully drained too. No hiding places left for the infection.
Okay, so drain the center, drain the sides, got it. And then the really specific Henley part dealing with the fistula tract itself, that fine line between cure and function.
This is the heart of it. The absolute core step is the midline sphincterotomy. And here's why it protects continence so well. The surgeon very carefully divides only the internal sphincter muscle.
Only the internal one?
Yes, just the internal one, right in that posterior midline, from the dentate line down to where the main abscess was.
Yeah.
The crucial thing, and this shows incredible surgical skill and knowledge, is the external sphincter is never divided.
Never cut the external one, okay.
Right. This opens up the plane between the sphincters, exposing where the fistula starts, but it leaves that main control muscle intact. Then they perform a fistulectomy.
Which means removing the tract.
Exactly. Meticulously removing the entire infected tunnel, or sometimes thoroughly scraping and cleaning it out, curettage and debridement. They probe it from the outside openings back to the inside one.
How do they find the inside one precisely?
Sometimes they'll inject a bit of hydrogen peroxide through the external openings. They watch for bubbles inside to pinpoint the internal opening. Very clever trick.
Wow.
Finally, marsupialization. This is where the surgeon sutures the edges of the wound created by removing the fistula tract to the surrounding skin.
Kind of like making a little open pouch?
Precisely. It sounds counterintuitive maybe, but it's vital. It stops the surface from closing too quickly, forcing it to heal slowly from the deep layers upwards. Prevents trapping infection again. They usually use absorbable stitches for this.
So it's not just cutting, it's knowing what to cut, how much to cut, and then setting up the healing process perfectly. That's incredible foresight from the surgeon.
It absolutely is.
Yeah.
And after all that, the wounds are deliberately left open to heal by what's called secondary intention.
Healing from the inside out.
Exactly. Bottom-up healing. It prevents abscesses reforming. They'll pack it loosely with gauze for maybe 2 or 3 days initially to help with drainage.
That level of detail really explains why it's so effective. But how does it compare to other ways surgeons might tackle similar problems? Why is Henley often the go-to?
Well, it has some major advantages that make it stand out, especially for these specific horseshoe cases. First, like we said, it's single stage.
One surgery, big plus for the patient.
Huge. One surgery, one recovery. Second, and this is critical, it preserves the external anal sphincter. That means a much lower risk of major incontinence, which is understandably a huge patient concern.
Right.
And third, the results are good. It has a really low recurrence rate, usually under 10%. So surgeons trust it to provide a durable fix.
Okay. Low recurrence, preserves function, one operation. Sounds great. Are there any downsides? Any trade-offs?
There can be. The main potential issue is something called a keyhole deformity. It's like a small indentation where the internal sphincter was divided. Sometimes it's going to lead to minor seepage or soiling for some people.
Okay, minor seepage. Manageable, usually.
Often, yes. And when you compare Henley to the alternatives, its strengths become even clearer, highlighting the decisions surgeons weigh.
Like what other options?
Well, there's seat and drainage. That's where a drain, like a thread or a rubber band, is put through the fistula to keep it draining. It's safe if there's a lot of active infection, but it almost always needs a second surgery later to actually treat the fistula. And the recurrence rate after seat and treatment alone is higher, maybe 15–30%, compared to Henley's 8–12%. So often it's just buying time.
More surgery, higher chance of it coming back. Okay. What about other techniques that try to spare the sphincter?
Good question. There are procedures like lift or using advancement flaps. These are also designed to spare the muscle. But they can be technically more complex. The surgeon has to work in very delicate tissue planes. And this is important. They generally don't work well if there's active sepsis, a really bad infection.
So if the infection is raging, Henley might still be the better option.
Often, yes. Henley can handle the infection up front. So what's really interesting is how Henley strikes this balance. Good results, preserves continence well, and often less complex than some other sphincter-saving options, especially in tricky infected cases. It's a really valuable tool for surgeons.
Okay, so the surgery itself is incredibly precise, but the surgeon's job isn't over then, right? What's recovery like for the patient? What happens after?
Absolutely not. Post-op care is crucial. It's a team effort. Pain control is important, usually with anti-inflammatories, maybe some stronger painkillers initially. And avoiding constipation is key. No
Right.
straining.
Right.
Wound care is huge. Daily sitz baths, just soaking in warm water, usually start after a couple of days to keep things clean. Loose packing might continue for a while until healthy granulation tissue starts forming.
New tissue growing in.
Exactly. And stool softeners or fiber are important too. Patients need regular follow-up, often weekly at first, until it's fully healed. This can take 6 weeks, maybe 12 weeks.
And during follow-up, the doctors are checking.
Checking healing progress, watching for any signs of infection, asking about continence, looking for that potential keyhole deformity, making sure everything is on track.
And the outcomes generally reflect all that care and precision. The success rates sound really good.
They really are impressive. For these primary horseshoe fistulas, you're looking at an 85 to 90% healing rate with Henley.
That's high.
Very high for such a complex problem. Incontinence risk is low, under 5%, and usually minor if that keyhole thing happens. Recurrence, as we said, is way down at 8 to 12% compared to setons alone.
And the keyhole deformity?
It happens maybe 10–15% of the time, but often pelvic floor exercises can help manage any minor issues. Again, it shows a comprehensive care extending beyond just the operation itself.
So, given how successful it is, are there times when surgeons specifically choose not to use Henley? When is it not the right call?
Excellent question. Because choosing the right operation for the right patient is just as important as doing the operation well. Huge responsibility for the surgeon.
Sure.
So Henley isn't typically used for patients with Crohn's disease. That condition needs a different approach. Usually long-term setons plus medications called biologics.
Okay, makes sense.
Also, not for high fistulas, ones that go way up above the main sphincter muscles called suprasphincteric. Those usually need a different technique, maybe an advancement flap.
Got it.
And one more important one, anterior fistulas in women. Because of the anatomy at the front, using the Henley approach there carries a risk of injuring the vagina. So surgeons choose safer alternatives in that situation. Patient safety first, always.
This deep dive really pulls it all together. The core of the Henley technique, like our sources described, seems to be drain the keystone, divide just the internal sphincter, remove the tract, and marsupialize. 4 very precise steps.
Exactly. And if you zoom out, thinking about the bigger picture, this specific technique really shows how vital that deep understanding of 3D anatomy is in medicine.
Yeah.
It's problem-solving at its finest, aimed directly at preserving quality of life. The surgeons who master this are blending deep knowledge with incredible technical skill. They're constantly refining things for their patients.
Absolutely. It really highlights how these specialized doctors and surgeons pour their careers into fixing these incredibly specific, complex problems. It kind of makes you wonder, doesn't it? What other fascinating niche solutions are out there in medicine that we rarely hear about, but that are completely life-changing for the people who need them? It's a good reminder of the sheer depth of skill and dedication involved.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.